Hello once again in our ultrasound course. Today we're going to discuss the gallbladder. The gallbladder is one of the most important subjects in ultrasound. Nevertheless, it's one of the underestimated subjects, being only treated as being normal or harboring gallstones. Of course, gallstones is the most important pathology here, but as we're going to see, there's more to the gallbladder than just gallstones, and even gallstones, we're going to see how to report it in the right manner and precisely. So let's begin our journey with the gallbladder. Okay, this is going to be our map in our lecture. Okay, this is what we are going to discuss. Of course, first of all, we have to know the normal gallbladder, how it appears. Okay, and then the congenital abnormalities, and then of course the stones and its precursor, the sludge. What if it caused inflammation, as in the acute cholecystitis? What are the complications that might happen? What if it's recurring and has caused chronicity, as in chronic cholecystitis? What are the polyps and the adenomyomatosis in the gallbladder? What's the carcinoma related to the gallbladder and other miscellaneous subjects? So this is going to be our map, what we're going to discuss in our lecture. Okay, let's start right away. What is the gall? Well, gall is something in Old English, especially before using it as an expression, is something very bitter. Perhaps it's used not first, but it's one of the famous writers used it. Shakespeare, when describing love in Romeo and Juliet, he said, what is it else, citing love, madness, most discreet, a shocking gall, and a preserving sweet, being contradiction. That's all this. So the gall is something very, very bitter. It's being here in contrast with preserving sweet, that is the honey. Of course, with love aside, and let's go back to medicine. Okay. This is the goal, okay? But I promise you that the lecture is not going to be anywhere near better. Okay, so the gallbladder, this sac that contains this bitter fluid, what does it do? Let's just know what does it do. Firstly, okay, the gallbladder lies here, okay, in its bed. And what does it do? First of all, the bile is formed all over the liver, okay, by the biliary system, the trans and the portal triad, along with the hepatic artery and the portal vein. And the bile is then collected into the right and left hepatic ducts, okay. Some of it is stored here in the gallbladder. So the gallbladder is a reservoir for the bile or the gall, that is the substance used in digestion. So when there is a call for digestion, for example, you eat our famous pizza, famous example, here the pizza is loaded with cheese and pepperoni and all this lovely stuff. So when you eat this lovely pizza and you have to digest it, okay, this stimulates the contraction of the gallbladder to inject the gallbladder here in the common bile ducts, the ampulla of bladder, the second part of the duodenum, where it is secreted in order to digest this lovely pizza. And that's why it's absolutely crucial to make the patient fasting for 6 hours at least before coming to the examination in order to see the gallbladder. Otherwise, if he is eating something, especially something in cheese, milk products, fats in general, all this will stimulate the gallbladder to contract, and therefore we cannot see it or diagnose it, okay? So this is roughly the function of the gallbladder, okay? Let's see the anatomy, or eternal, never-ending medical science. Okay, The anatomy of the gallbladder. Gallbladder has three parts. First, the fundus, and then the body, and then the neck. Okay, so we have three main parts of the gallbladder. The fundus being furthest from the porta hepatis, and the neck, the narrowest part, and the body in between. And then the cystic ducts. Okay, it ends by the cystic duct that forms with the hepatic duct the common bile duct. Okay, let's see another picture. Okay, voila. Again, the anatomy. This is the fundus. Okay, let's choose another color. Wait a sec. Where is it? Okay, voila. So this is the neck. And here there's a wider part here. It's considered to be part of the neck. Okay, but it is a little bit wider here. And this part is called infundibulum. Okay, and then there is the body, and then that is the fundus. So these are the parts of the gallbladder. Then there is the cystic duct that forms with the hepatic duct, the common bile duct. Okay? Okay. Again, the anatomy. In this diagrammatic picture, we can appreciate more the infundibulum, this part. It's also called Hartmann's pouch. Well, why are we specifying this part of the neck, describing it and giving it another name? Well, it's not to make your life hard, but it has clinical importance. If a stone is impacted here, okay, this will exert compression on the cystic duct and therefore the common hepatic duct. And when the common hepatic duct is compressed, thus obstructed, this will cause biliary obstruction, okay, and a condition named Marizzi syndrome. Okay, voila. So this is the clinical importance of this anatomical part, the Hartmann's pouch or the infundibulum of the gallbladder. This little bit wide part just next to the neck, the narrow neck, is called the infundibulum. And then the rest of the gallbladder, here the body of the gallbladder, and there is the fundus of the gallbladder. Okay. So let's go to the ultrasounds. How these things look here. This is the fundus of the gallbladder being furthest from the porta hepatis, as we just said. And then there is the body, and then there is the neck with a little bit wider part, that is the infundibulum. Okay, what about the measurements? When we see the gallbladder as such, we have to make some measurements. First, the length. Okay, the length of the gallbladder should not exceed 10 centimeters. Then there is the width. The width should not exceed 4 centimeters. We've got these two numbers. Are there any other measurements that we have to measure? Bravo, excellent. We have to measure the wall thickness. Okay, so we've got two walls here, this one and this one. Which one do we measure? Wall A or B? Well, absolutely right. Wall A, that is the anterior wall, that is the wall adjacent to the liver. We do not measure the wall thickness in the posterior wall. And there is another thing, it has to be in this orientation, that's to say the longitudinal section. Okay, so in order to measure the gallbladder wall thickness, it has to be in the longitudinal section, LS, and it has to be the anterior wall. It should not exceed 3 millimeters in thickness. Okay, so that is the measurements, standard measurements when we examine the gallbladder. Another picture. Here, what are the anatomical parts here? Fundus, yeah. The body, the infundibulum, and all of this is the neck. This is the body. This is the porta hepatis. As we said, the nearest to it is the neck. The furthest is the fundus. And this is the Mickey Mouse face. Yeah. Okay. Wow. Here, this is the gallbladder. This is the fundus. And all of this is the neck. But what is this? You see something new here. What is this? I see that some of you say that it's a septum, and some say it is a fold. Now, which one is this? Well, those who said fold, you are absolutely right. Do you know why? Because fold is more or less like the septum, but it is incomplete because it didn't reach the other wall. So the septum has to be complete from wall to wall. So this is a septum, the one I'm drawing. But this is a fold because it did not reach the other wall. So in other terms, it is incomplete septum. Thus, this is only a fold because it is related to one wall. Okay? So this is a fold, and this is a normal variant, not necessarily mentioned if it's not complicated with anything in the report. Okay. Another picture. It's absolutely important to memorize how it looks and get used to it. This is the what fundus, and this is the neck. All of this is this special part that is the infundibulum or the Hartmann's pouch, and the part in between that is the body. Bravo, very good. Okay, here another picture. Okay, what's different here in this picture? Yeah, the stones, the famous stones. We have here stones. But still, what are the parts? Huh? What is this? Right, the fundus. Yeah. And what is this? All of this. The neck. Bravo. What is this part? The little white part here. The Hartmann's pouch or the infundibulum. Absolutely correct. And in between, this is the body. What about the measurements? This is the length, and what it's the number. It should not exceed 10. And this, how about the width? It should be under 4. And if we want to measure the wall thickness, we would measure this wall or this wall. Yeah, the anterior wall, the one that is adjacent to the lip. Absolutely correct. So this is for the anatomy and the normal measurements. Here is how it looks by the CT. Of course, in the CT, things look a little bit different. The fluid does not look black as in the ultrasound. It looks here as in gray, hypodense. But what does look black in the CT? Yeah, the air. The air looks jet black. This is the air in the bowel. It looks jet black. And here, another structure that looks black too, but not jet black. This is the fat. Looks dark, but not absolutely black. And this is the fat. So things look a little bit different in CT, but whenever needed, we will make the correlation. What about the blood supply? The gallbladder is supplied by the cystic artery. Cystic artery is a branch from the hepatic artery. Okay, from the hepatic artery. This is red too. Okay. The cystic artery is a branch from the hepatic artery, and it is branched from the celiac trunk that comes directly from the aorta. Okay, so this is the the blood supply, okay, of the gallbladder. The cystic artery has two branches, anterior branch and posterior branch. Okay. Do you see this stuff in ultrasound? Well, yeah. Okay, and we should. This is the cystic artery. We see it along the wall. Obviously, this is the anterior branch related to the anterior wall. So we can see it running along the wall. Of course, by the aid of the Doppler, of course. We have to adjust our Doppler settings, okay? And then we can see it. Okay, let's see another picture. Voila, this is how it looks. Voila, here. Along the wall, the anterior and posterior wall, but this is along the anterior wall, okay? And this is how we can see it after, of course, adjusting our Doppler adjustments. This is the main lobar fissure, which is an important anatomical landmark here. The main lobar fissure lies between the porta hepatis and the gallbladder, okay? Here, the cystic duct. Okay, the cystic duct is called peculiar composition or peculiar formation. It's this lumen that is spiral form. Actually, this is a valve inside the cystic duct, okay? And it's called valve of Hester. And it has this spiral form or serpentine, whatever you call it. Important thing that you know that it looks like this. So if you see it like this in the ARCB, for instance, in spotting exam or something, you can easily know that this is a cystic duct, and you will not confound it with the common hepatic duct, because the cystic duct is always looking like this. The common hepatic duct is straight as such. However, the cystic duct always has this spiral form, so it's fairly easy to differentiate it from the hepatic duct. Okay. Can we see this in ultrasound? This is the important question. Well, you can, but this is difficult. It would need a good, powerful machine in order to see it. But should you see it, it looks like this, very small. The importance of this is you should know how it looks, because on the off chance that you see a stone related to this, you will know that this is impacted in the cystic duct. But generally, yeah, it's difficult to see. Okay, so we finished now the normal anatomy. This is part of the normal variants to the folds. Okay, we've mentioned or we've seen a fold before, and we have stated that it should be incomplete as such. Okay, and this is how we know that this is a fold, not a septum. Now we have two folds that is really important, and we can see a fold at the fundus here. This fold is a fundal fold or that forms the virgin cap. So this is the virgin cap, and here the fold is in the fundus. The second important fold is the fold related to the neck here. Okay, and if we have more than one fold, okay, as here we have more than one fold, this would give the gallbladder the appearance of the sigmoid colon. Thus we call it sigmoid, okay, because it would have its loop, it's taking the form of the sigmoid loop, okay. So these are the folds related to the gallbladder. Okay. Here, the multiple folds giving the gallbladder the form of sigmoid colon. Now, to the virgin cap. Well, the virgin cap is named after this strange thing. Of course, nowadays we do not see it anymore, but Mr. Scientist or physician who have seen it first, he said, oh, this looks like the virgin cap, and thus it's named virgin cap. And I think this is the jester or joker or anything, but the important thing is that they fold like this, and it makes this, the fundus look like this. Okay, so this is the virgin cap we see in the gallbladder, and this is why it is named as such. Okay, so we remember this by this little gesture or guy. This is how it looks diagrammatically. This is by the ultrasounds. Okay. Okay, by the ultrasound. This is the fundal fold. Okay, this is obviously the fundus, and this is the fold. This is how it looks by CT. Of course, here the CT resembles in the ultrasound the TS, okay, being a transverse section CT, this orientation of the CT. So we see it here as if two lumens, but of course it is one, and this is a fold. So if we just have seen all the sections, we would know this. In the ultrasound, of course, we can change the orientation easily and make sure that it is, yeah, this is it. This is the orientation when we have seen this, okay, this is LS, okay, and if we have cut it, if we change the orientation and see the view from this point of view, as in here, we would see it as if there are two gallbladder duplicate or something, but the fact of the matter is that there is no duplication. This is just the view at this level, okay? Now, that's why it's important, of course, always when you find something that you see it in two views. This way you would know how it looks in more than one plane and make sure of its orientation, okay? So this is the fundal fold, the virgin cap, another picture. Here, the virgin cap here, okay, and the fundus, okay. This is the importance why we are seeing all this picture and the name and everything, because the virgin cap is a site of infection of the stone. So when I see a structure like this adjacent to the gallbladder with this echogenic focus, okay, casting shadow, what would I think? What are the possibilities? Let's try together. Of course, this could be merely the duodenum, okay, or could be a lymph node with calcification, right? And can also be what? It can also be it can also be part of the bowel, okay? So what to do? Okay, we will change orientation in order to see what is it. Okay, let's do this. Voila. When we have changed the orientation and seen it's another plane, now, what is it? It's part of the gallbladder, and this is a fundal fold. This is a fundal fold, and this is a stone impacted in this part of the gallbladder. This is the virgin cap, okay, and this is a stone impacted here, okay, by the fold of the virgin cap, okay. So when we see this, there's a first possibility that this is part of the gallbladder, and this is merely a fold. Now, in order to imagine it, okay, let's see how it would look diagrammatically. This is the gesture we've just seen, okay. That's quite miserable, okay. And this is the virgin cap he's wearing, okay. Now, the virgin cap is dangling as such, okay. And there is the stone here or here. And I take section as such. I would see part of his cap and the other part of the cap just adjacent to it. At this level, or at this level, I would see part of his cap and the virgin cap, okay, the original cap and the virgin cap next to it, as if it is separate. But the fact of the matter, it's not separate. Okay, so this is why they look next to each other as if they are separate, but they are not separate. When we change the orientation, we see it as such. And this is the stone here. Okay, so it's really very important to change the orientation and to see the pathology or the finding in more than one thing. Okay, in order to make sure what it is. So this is the importance of the virgin cap. Can be site of impaction for stone. Another picture here. We see it as an adjacent to the gallbladder. However, it is part of the gallbladder. Okay, so that was the folds and the anatomy. And now this is a something called edge refraction shadow. As we know that the structures, the hollow structures that contains fluid, they have what we call the edge refraction shadow, such. So they might falsely give us the appearance that, okay, let's see it one more time, that there is a stone with shadow in here. But of course, if we have changed the orientation and seen it in one plane, I have to make sure that this is not just merely the edge shadow refraction, so it's worth to know that there's something as such. Okay, so we have finished now the normal bladder ultrasound with the folds. Okay, that's part of the normal variance. Okay, so let's see the congenital abnormalities. Okay. What are the abnormalities that can be in the gallbladder? Okay. What happens if we do not see the gallbladder? What would you think? First of all, that the patient is not fasting. Of course, typically, the patient might be fasting properly. He might have eaten something and he's forgetting, or he is just claiming that he's fasting in order not to miss his diagnosis, not knowing that is not just a structure that's important for us to see all the structures. So he might not be fasting. Okay, what if he was fasting and telling the truth and everything, and still we do not see gallbladder? He might have been what? The gallbladder might have been surgically removed. So we have to ask him, did you have it removed? Do you have history of operation? Okay, what if patient is fasting and everything and he doesn't have any history of operation and still we do not see the gallbladder? Well, if it is like this and we believe him and everything, then we might think of agenesis of the gallbladder. Okay. Agenesis of the gallbladder, we have to confirm with another test, like the Hyder scan. Okay. It might be present, but it might be very small and might not be present. Okay. Yeah, we have to make the Hyder scan. Okay, in order to make sure that it's not really present and it might be very small. However, the patient might not be complaining because the bile would be excreted directly into the common bile duct and the bowel. Okay, so the function of the bile might be there, but with no reservoir. All right. Okay. These are the other possibilities of not seeing the gallbladder, not just agenesis or patient not fasting or surgical removal. There are other things like the porcelain gallbladder, like the emphysematous gallbladder, and like the ectopic location. It's there. And here it is. This is the second abnormality here, that the gallbladder normally is related to the main lobe refractor, however, it could be in other anatomical sites as such. And in this case, we'd call it ectopic. Now, let's see. Here, the gallbladder, here, it's where? It's in segment 2 or 3. This is the left lobe, right? This is the left lobe. And here, the gallbladder is in segment 2 or 3. So this is not, of course, the anatomical position. So this is a ectopic. Let's see another example. Here, the gallbladder is where? It's in segment 7. It should not be there. It should be between 4 and 5. So this is also ectopic location. Okay? How would we know that this is the gallbladder? Okay. The patient is fasting with no history of operation, and we see no gallbladder in its anatomical site. And yet we have this globular structure, beer-shaped structure here. So most probably this is going to be your gallbladder. Okay, another abnormality here when the patient has 2 gallbladders. Oh, great. And who are the lucky people who would have it? Typical males or females, or the lucky ones? Males. Females in the gallbladder is most unlucky. They have more incidence of forming stones and diseases of the gallbladder, the stones, and they don't have this. The male have the gallbladder duplication more. So if one is not functioning or having stones or anything, you would have another. So poor females. Okay. All right. Another picture for the duplicate gallbladder. They are complete. Make sure in more than one plane. If you see this and suspect the fold, see it in another plane. If it's like this, okay, then this is duplication. This patient's unfortunate. He has two gallbladders and the 2 harbor stones. Okay, here, if we see this once again, what would we think? This is duplicated or fold? See it in another plane. In this plane, we can see that it is what? It is not duplicated, it's merely a fold. And this is called what? What kind of fold? Or does this fold has a name? Yeah, this is the virgin cap. Okay, remember the little jester boy wearing the cap. Okay. So we've seen the ectopic, the agenesis, and the duplication. Okay. Is there other congenital abnormalities? Yeah, the septum. We mentioned before that the septum differs from the fold that is from one wall to the other. So this is a complete septum. However, the septum might be multiple as such, and thus it would be, if it is multiple, it would look like this, the gallbladder. And the septum has to be mentioned in the report because it's related to more complications. Okay. Okay, so yeah, I have another picture for the septum. Yeah, this is it. Yeah, this is not a fold, pardon. This is the septum. Yeah, because this is an LS2. So this is the septum because it is from one wall to another. Thank you for reminding me. Yeah, this is it. It's from one wall to another. This is an LS2, but here, this is the differential diagnosis for the septum. This is the septum, okay, and separating the lumen into 2 spaces as such. But here, this is incomplete, okay? If we see this by in the transverse section, the transverse view, we have then to check by the LS in order to make sure that it's not merely a fold. Okay? All right. If the septum is multiple, it would look as such. Okay? The multiseptate. But either way, if it is single septum or multiseptum, we have to mention because it is liable for complications. Okay, here it is. This is a multiseptated. As we can see, each and every one of them has relation to two walls. This and this and this and this. Okay. Another abnormality, but it's rare, we won't say it much. This is the outbouching of the wall in what it is called diverticulum. Okay, another example here. This is outbouching of the wall, and this is the diverticulum. However, it is not so very common. Another not so very common abnormality. Okay, before we see it, let's see another example of the diverticulum. This is how it looks by the MRCP. Okay, of course, if we see it like this, okay, we have to report it. And this is the floating gallbladder. The other abnormality, I was telling you that it's not so very common. So, yeah, it's floating in here. And this is another example. However, they are not so very common. So, let's make a quick recap. Okay. What have we discussed so far? Yeah, I want you to start with me. We have discussed the anatomy of the gallbladder. Now, the gallbladder is a ear-shaped structure with what dimensions now? What about the length? Bravo, 10 centimeters. Yeah, the width, 4 centimeters. Bravo. What about the gallbladder wall thickness? Do we measure it here or in the interior wall or the posterior wall? Yeah, the interior wall related to the river, and it should not exceed 3 millimeters. Okay, so that's for the dimensions and the anatomy. The parts, we have the fundus, the body, the neck, the narrow part, and the infundibulum, the little white part related to the neck or the Hartmann's pouch. Then the folds, the most important folds we have, one related to the neck and the other related to the fundus, and this one is called the virgin cap. Bravo. Okay. Now, what about the congenital abnormalities? What are the congenital abnormalities? The agenesis. And we have to make sure by doing the HIDA scan. Bravo. Okay. What other abnormalities? Duplication. We have two. That's more common in males. Ectopic location. Elsewhere than it should be. And the septum has to be reported, and it could be multiple. What other abnormalities? We have two other, not so very common, that is the diverticulum and the floating. Bravo. So that's all for the anatomy and the congenital abnormalities. So let's go on. Okay, back to our map. This is what we finished, the normal and the congenital abnormalities. Now to the famous gallbladder stones. Let's attack. Okay, the gallbladder stones and the sludge. Okay, so we have to differentiate between the gallbladder stones and the acute cholecystitis. The acute cholecystitis, the patient would be devastated. She would be in pain. Okay, most probably she would be a female because more common in females. But in patient with a gallbladder stone, she would come to you with the clinic calmly, and she would complain of attacks of pain in the right hypochondrium or on the right side with the cooling sign. What is the cooling sign? That is pain under the right scapula as such, and the patient would relate to this. There are certain risk factors more common in patients with gallbladder stones. Of course, as we stated more than one time, that it would be a female. It's more common in females. And fat here, yeah, that's having the body mass index more than 30. And let's not just say fat, because I know that there are many grades out there listening to us. ladies, of course, it's not fat, it's curvy, it is plumpy, it is whatever it is, but if the body mass index, and that's the important thing, is more than 30, whatever it's called, this is a risk factor. Being fertile, having one or more children, being over 40, and having family history, as in other members of the family suffering from the same thing, the gallbladder stones. So these are the clinical picture of the gallbladder stones. Now the stones can be formed of what? Okay. In the gallbladder, we have, of course, the bile. Okay, the bile is fats. Okay. So it might, condensate and precipitate and form the stone. So the stone can be formed merely of fat only, that's to say cholesterol stones, or calcium can precipitate on top, and thus it will be mixed, and this is the most common. It's more common than pure cholesterol stones to be mixed, and when the calcium is formed, it will give it the characteristic criteria we'll see later. So the formation of the stones and its composition, it's important because this will affect how we can see it. Okay, these are the cardinal criteria for diagnosing the stone, being, first of all, ecogenic. As such, voila, it's very ecogenic, almost white. Be casting shadow, here it is, shadow, because it would obliterate the ultrasound beam and thus it would have black shadow. Gravity dependent, okay, and mobile, that's when the patient changes his or her posture, the stone location will change as well. Okay, let's see. All right. Okay, this is the shadow of the gallbladder stone. Okay, do all the stones exhibit all the 4 characteristics? Well, no. Let's see how. But first, let's see this typical stone. This typical stone is ecogenic, it's casting shadow, it is dependent, and it is mobile. Okay, here it is, another typical stone. Okay, the stones can be multiple and small as such, okay, and thus we'll call them confluent. In the previous cases, when we see gallbladder stone as such, we do not say cholecystitis. We just say gallbladder stone and we measure it and write it. Here, if we see very small as such, we write multiple small stones and we try to measure the largest or the smallest. Okay, they might cast a huge shadow as such, okay, or not. If they are very small, or they are small as in here, they might not cast shadow, okay? Why, this is the very first exception to the 4 cardinal rules. The casting shadow, as we said that the 4 cardinal rules are not always present, and we would see those exceptions. First exception, when a stone does not cast a shadow. Well, for a stone to cast a shadow, it has to obliterate the ultrasound beam as such. Okay, this is the ultrasound beam and tends to spread in this manner. So if the stone has prevented it, then it will cast this shadow. What if the stone is small? Okay, it might not cast shadow. What if it is not in the field of view? What if it is away from the focal zone or the focal point? These 2 things are related to your machine settings or your physical adjustments. So yeah, the stone cannot cause a shadow if it is small or if your adjustments are not optimum to show its shadow. Okay. Let's see this in ultrasounds. Okay, voila. This is a stone. Okay, this is the first exception. This is a stone that's small and does not cast a shadow. The stone is here. Okay, small stone, and it has no shadow. Still, it is a stone. Okay, it's ecogenic. and it will be mobile, and it is dependent, but it does not have a shadow. Here, there is another stone here, okay, and that doesn't have shadow. But the problem here is not about its size, it's about the adjustments. When the adjustments are straightened, okay, calibrated right, here is the shadow. Okay, as we said, there's other physical related settings we have to set right in order to see it. Okay. The second exception, we said that it should be what? Gravity dependent. Okay, we have this stone. This is fairly typical. It is echogenic, it casts a huge shadow here, and it is dependent. Okay, this is real time, see? This one seems to be floating up there, okay, floating over the fluid here. Why is this? Because here the composition, the part that we've said is partly important, this part, and it's not really very echogenic because this stone is polystyrol stone, okay? So just like fats and oil, it floats over the fluid. You have a glass of water, okay, and you put some oil in it, drops of oil or fat or butter or whatever, okay, in the fluid form, it will float. It will float. And this is what happened. The polystyrol here is floating. So this stone is floating, okay, and it has a shadow. It has a shadow, but it is floating. So as we've said, this is the second exception. Some stones cannot cause a shadow, and some stones can be floating. Okay. Another example of floating stone here. It has a shadow, voila, but it is floating. Okay. Other thing is the stones that are not very echogenic. If we see this picture, okay, let's do it this way. If we see this picture at first, okay, this is not so very echogenic, and we have two of these small stones, and they don't cause shadow, all three of them. What would we think? We think there are stones, or rather polyps, which relates to the margins, not so very echogenic, then we have shadow, all of this. What would we do? We'd have the patient change his posture on the others. Now, these two has moved, thus they are what? They are mobile, but this one didn't move. So yeah, this is a polyp, yeah, but these two are stones because they are mobile. Okay, so another exceptions, another atypical stones, but they are stones nevertheless. They are here sludge balls. Okay, like cholesterol stones, but huge. Okay, here we've said in the example before that stones are mobile. So are all stones mobile? No. We have here the last exception that the stone can be not mobile. Here it is a small, there is echogenic, it casts shadow, okay, but it does not move. Okay, why is this? Because it is impacted in the neck. How can we be sure? We can use the Doppler, and the stone will produce what we call twinkle artifacts. So here, twinkle, twinkle, little stone with the Doppler. All right. So stones can be not echogenic. Stones can not cause a shadow. Stones can be fixed, not mobile. Okay. Stones can be not dependent and floating. So yeah, all exceptions are there. This is another example of an impacted stone in the neck. This is real time, as you can see. Okay. What are the other side of impaction that we have mentioned earlier? Bravo, the virgin gap. Here, the virgin gap. Why is this? Because in these two cases that we've said, We have this fold at the neck and this fold at the fundus. And due to these two folds, and stone can be impacted here, and the stone can be impacted here, okay, related to these folds, or the narrow neck, okay? And that's why the neck and the fundus, in case of virgin cap, can be sites of impaction of stones, okay? So yeah, the stone can be not mobile. What if we want to see it in the X-ray? Okay, a stone here, okay, in the right side, could be what? Could be from the gallbladder or could be from the kidney, okay? How to know? This view is what? This is the AP view. We'd ask the patient to have another view, that is the lateral view. Now, if it is the gallbladder, it would appear as such. If it is the kidney, it would appear overlying the spine. So here the stone is where it is in front of the spine, so it is gallbladder. But if it was overlying the spine, then it would be a renal stone. So this is how we can differentiate. Is it a gallbladder stone or renal stone by the X-ray? But of course, the best modality for the stones are the ultrasound. So let's strap together the gallbladder stone. Okay. So the stone, the gallbladder stone, as we've said. Okay. First, we have discussed the clinical picture, the 5F. Okay. Fat and female, fertile, 40. Okay. Fat, female, fertile, and 40. Okay. Huh? What was the fifth? What was the fifth? Family history. Yeah. Family history. Okay. The stone formation. It is either cholesterol pure or mixed. Mix it as in with calcium. What are the four cardinal rules? It is echogenic. What is the exception? Can it be not echogenic? Yeah, if it is, cholesterol. Stone only, without calcium. The second thing, it casts shadow. Okay, can it not cause a shadow? Yeah, if it is small and if your adjustments are not right. Okay, the other thing is that it is dependent, gravity dependent. Can it be not dependent? Yeah, if it is floating, as in the cholesterol stones. Okay, other thing that it is what? Mobile. Can it be fixed? Yeah, if it is impacted. Mostly where? In the virgin cap, in the fundus, or at the neck, Hartmann's pouch. Okay. So this is the summary of the gallbladder stone. Okay, so now let's see the precursor of the stone. Before formation of the stone, mostly the fat or the bile starts to accumulate or aggregate as such, forming what's called sludge or mud. It can, of course, confluent and aggregate in a single focus, that is the stone, or be as such, precipitate here, as in the sludge or mud. The two terms are the same. Okay, let's see how this looks in the ultrasound. Okay, voila. This is the mud or sludge. But if we see this in ultrasound, of course, we think of sludge or mud. There are other differential diagnoses. There are other possible things. The pseudo sludge, we see later what is this, or the blood in case of trauma patient. Okay, there is injury of the gallbladder, and thus when the patient has fever and elevated white basic count, or something called milk of calcium part. We'll see them all, of course. All right. Okay. This is the sludge. As we see, there's a level. There's ecogenic matter here. When we see sludge, we have to report it, of course, and we can say that whether it is mild amount or moderate amount. Here in this picture, it is moderate amounts. The sludge can aggregate together, okay, can aggregate together as such. And in this case, we would think also of soft tissue mass, right? This could be sludge that's aggregated, or could be softish mass inside the gallbladder. How to know? We can ask the patient to move, and the sludge ball or the sludge aggregate would move. However, there's better thing, and that is the Doppler. The color box. If we have turned the Doppler on and the color box is such and there is no color flow inside, then it is more likely to be sludge. Okay, we can make sure of it so the Doppler is more reliable. Okay, here the sludge with the stone. Okay, here the pseudo sludge. When we see sludge inside the gallbladder, we have to make sure it is not an artifact from the duodenum. Okay, the duodenum, this is the duodenum, okay, with the air inside of it, can cause an artifact, okay, an artifact that is a pseudo sludge, giving the appearance of sludge while it is not really sludge. Okay. So we have to make sure, make the patient move another decubitus and look at it for more than one day to make sure that it is not merely an artifact. Okay. Perhaps drink some water. Okay. So this is the hepatization of the gallbladder. This is when the sludge fills the whole of the gallbladder. See? The whole of the gallbladder is filled with sludge. So it looks almost like the liver adjacent to it. This is hepatization of the gallbladder. Another picture. It looks like being almost part of the liver. Okay. Hepatization of the gallbladder. Another picture. Hepatization of the gallbladder. In this picture, we have something that resembles sludge. But remember, with the history of trauma, this is not sludge. This is injury in the gallbladder, and this is blood precipitate inside it. Again, a case of trauma. Here, what the inside of the gallbladder, this is not sludge, this is blood with precipitate level. Okay, this is the milk of calcium. Okay, let's see what the milk of calcium is. Okay, the milk of calcium. When there is a sludge in the gallbladder, as such, sometimes the calcium precipitates on the surface of the sludge, making this line. Okay, it looks like this. We have this ecogenic line, this sludge in between, and of course it goes through shadow because it is what? Calcium. When we see this, we can make sure by either the CT or the X-ray. In the CT, it is very impressive. See, all of this is calcium contained, as if we have poured milk into the gallbladder. So this is how it looks. Okay. This is the milk of calcium. Another picture of the CT. This is the ultrasound, and this is by the X-ray. Okay. So we have finished now the gallbladder stones and the sludge. Congratulations. Let's make a quick recap of all what we have said. Okay. The final summary before the second part. Okay. The gallbladder, the anatomy. What are the measurements? 10 centimeters by 4. What is the thickness? 3 millimeters. Okay. And which wall do we measure? The interior. Bravo. The parts of the fundus, the body, the neck with the infundibulum or the Hartmann's pouch, the folds, we've got folds, the most important one, what? The virgin cap and the fundus, virgin fundus, okay, and then the congenital abnormalities, first of all, agenesis, okay, we do not see the gallbladder, we have to make sure by the HIDA scan, okay, other, of course, differential diagnosis for not visualizing it, duplication, if there is 2 gallbladders, more common in males, ectopic, when it is not in its position, what other congenital abnormalities? Okay, septum. It could be single or multi-septated, and this we have to mention in the report because it is more integrated, it's more liable for complications. Other two, not so very common, that is the diverticulum and the floating gallbladder. Okay, so these are not so very common. What about the stones? As we said, we have to differentiate between stones and polycystites. Stones, they are what? Either polystyrol pure or mixed. What are the 4 cardinal criteria? It has to be ecogenic. It can be not ecogenic if it is pure polystyrol. It has to cast a shadow. It cannot cast a shadow if it's a small or the adjustments are not set right. And it has to be what? Dependent, that can be floating if it's pure polystyrol. Other thing, it has to be what? Mobile. It can be not mobile if it is embedded in the neck or in the virgin cap. All right, then we have the sludge, the precursor of stone. What is the differential diagnosis of sludge? It can be sludge, that is the biliary mud, okay, that's the precursor of stones, and it can be pseudo sludge, reverberating from artifact from the duodenum, okay. It can be pus if the patient has fever, elevated leukocytes. It can be blood if the patient has a history of trauma. It can be milk of calcium, that is sludge, but with calcium on top. Okay, and that's all, and thank you.